multiple issues with the diagnosis of Lyme disease. It relates to probably three different areas. The first is the clinical assessment or the clinical diagnosis. The second area is actually the laboratory testing, and the third area is the issue of co-infections. The clinical diagnosis of Lyme disease relates to the presentation of the patient when he goes to see his clinician. Classically, the bullseye rash, the erythema migrans, is thought to be diagnostic of Lyme disease, given other symptoms and history. The problem with diagnosing a patient only with the bullseye rash is that this rash can have multiple manifestations in different individuals, and sometimes the rash will not be apparent. It could be hidden. It could be hidden in the hair. It could be hidden on the back. The patient may not realize it. So a clinical diagnosis without laboratory confirmation, I think, contributes to misdiagnosis. Coppe Laboratories has evolved a very thoughtful approach to the laboratory diagnosis, laboratory testing for Lyme disease. We screen patient sera for antibodies to multiple of the Borrelia species, genospecies. Our concern is missing a Borrelia bacteria infection, so we screen for multiple bacteria that are associated with Lyme disease in this country and in Europe. So that is very much an enhanced screening approach over what is traditionally done in the United States. In addition, our confirmatory testing, which is often called the Western blot or immunoblot, in that assay, we again enrich for some of the most common immune targets that patients respond to when they're infected with the bacteria. And our assay includes an objective measure of reading what we call bands on the blot in these assays. So usually the case is this test is read by an individual's eye, so you have a technical person that has to make a subjective judgment in, is that band positive? Is it intermediate? Is it negative? We don't rely on subjective interpretation. We have computer scanning software to where we measure and record the intensity of the banding in this test, so that it is an objective measure of positivity or negativity, again, in the confirmatory test for Lyme disease. And indeterminate results in many other laboratories are fairly frequent. At Coppe Laboratories, the frequency of an indeterminate result in our laboratory assay is less than 4%. So we have tried to meet the challenge of providing definitive results in patients potentially infected with the Lyme disease agent, so that physicians can embark on the most appropriate treatment regimen for that specific patient.